And welcome to this evening's session, which is a joint teaching webinar between the FRCS Mentor Group and OR UK. My name is Nikki Evans and I will be your host for this evening. The rest of the faculty include Imogen and Hannah from OR UK and my fellow mentors, Shwan, Hani, David and Hussam. This evening we are delighted to welcome Mr. Mark Latimer and Mr. Prani Budave, who are both consultant orthopaedic surgeons at Addenbrooke's Hospital. Mr. Latimer graduated from both Oxford and Cambridge in 1997 and did his orthopaedic specialist training on the East Anglia rotation and Cambridge. He was awarded the prestigious Ingham Fellowship in Sydney and worked with Dr. David Little. And earlier this year, he was awarded the Certificate of Excellence from the I Want Great Care group. So this evening's lecture will be more interactive than usual. So we will be having some case discussions with some teaching points and tips for the exam throughout the webinar. And for that reason, we'd ask for people to volunteer to have some Viva practice with Mr. Latimer and Mr. Budave during the session. Now, this part of the session will be recorded, so if you don't want to be recorded, please let us know. As always, we ask if you have any questions to put them in the chat, and we will keep an eye on that. We'll ask any questions at the end of the session. Any participants who wish to stay on for Viva practice, please raise your hand and let Hannah and Imogen know whether you want to be part of the webinar or whether you want to be the practice at the end or whether you want to do both, which is fantastic. We do understand that putting yourself forward in this forum is really stressful, but we're all here to help. All of us have been through this, and it is the best way to get that training that you need for the exam, particularly with regards for your technique. And, you know, as we all know, having passed the exam, and quite recently, we've had some positive feedback from people who've been in this group as a participant who've also passed the exam in the last week. So congratulations to them. And so this way of teaching does actually work. So our next course for the exam will be on Thursday, the 2nd of September, and there are participant and observer spaces available. You can book this via the OR UK website, and it's on a Thursday, so you'll need to remember to book study leave early. We recommend our textbooks from OR UK and ourselves. And without any further delay, I am honoured to hand over to Mr. Latimer. Thank you very much.
Thank you very much, Nikki. I will just share screen. As I'm sharing screen, please do enthusiastically put yourself forward for the case discussions, because I can't emphasize what Nikki said strongly enough, that the way to learn is actually through to some degree putting yourself to the test, and that's what I would really like everyone to do. This is nothing to do with sort of proving one another to be sort of better or clever. It's all about working together to help you guys to achieve your goal, which for the purposes of this evening, I trust for all of us really is to pass the FRCS and to sort of proceed on in a career in orthopaedics. Let me again introduce myself, although Nikki has already done that very flatteringly. My name is Mark Latimer. I'm a children's orthopaedic surgeon primarily, although I do also do some adult work. I'm still on the adult trauma rota at Cambridge, so I have a fairly general practice. And my background in orthopaedics, as Nikki said, is that my background in pediatric orthopaedics was a fellowship year at the Children's Hospital in Sydney with Professor David Little and Michael Belmore, which was a very intense experience. For those of you who keep a careful logbook. I did 850 cases in a year. Some of you will say, I suspect, that's not many. In comparison to training in the UK, that's quite a lot. So one of the things that I want you to be confident about by the end of this evening's webinar is in discriminating between those things which are friendly and benign and those things which have the potential to come and bite us. I'm going to ask, is it Metwali Sadamad, who has his hand up? This is not the question you're expecting, but can you unmute yourself, or I'll ask. I'll unmute you. Do you have any idea what sort of animal this might be?
Whales, I think it's whales.
Yeah, so that's you're almost certainly right. It has a sort of certain cetacean profile to it. Would you be confident enough that it is a friendly dolphin to actually jump in the sea and have a swim with it?
Yeah, exactly. Yes.
Well, I wouldn't. As somebody who spent a year in Australia, although dorsal fins on the surface often are friendly dolphins, and it's good fun to swim with dolphins. Every now and again, this is what the dorsal fin turns out to be. It turns out to be something that's dangerous and comes to bite you. And why on earth are we talking about dolphins and sharks in an orthopedic lecture? Well, the answer is that one of the things that that we need to sort of learn together is how to fairly quickly assess from what sometimes, particularly in children, are fairly subtle and fairly non-specific signs, whether or not what lies beneath the surface is something benign or something dangerous. So when I'm talking about dolphins and sharks, I'm talking about the difference between, you know, a simple torus fracture of the wrist and something which actually turns out to be osteomyelitis or some sort of neoplastic process. And discriminating between the one and the other is particularly difficult, I think, in children, because they so often can't tell us exactly what's going on. The remit of the FRCS essentially is to identify those people who can demonstrate an ability to work competently at the level of a newly appointed consultant, to be able to identify emergency presentations, also to recognize your limitations and to know how and when to get help. And it really is as simple as that. It's not simple. It's challenging. It's a big and broad based knowledge that's required, and also an ability to think and to reason. I'm going to pass this one on. Well, no, actually, since you answered so beautifully well, Metwali, forgive me if I'm not pronouncing your name correctly. Do you have any idea who this might be? I'll ask you some proper orthopedic questions later, I promise. You're on mute again.
I am not sure, but this I can say is Aristotle. I don't know. I'm not sure.
Yeah, so I don't think anybody knows terribly well what either Aristotle or this chap looked like, and they were very nearly contemporaries. Anybody from the audience want to hazard a guess who this is? This is Socrates, and Socrates very famously, Socrates may be regarded as one of the pioneers of teaching. And what Socrates, after trying various methods of teaching, established and then demonstrated was that the best way to teach is not to tell people things, but to ask them questions. And so that's what we're going to do today. Some of the cases will be very difficult. The fact that they're difficult doesn't mean that they should, in a sense, represent any more of a challenge to you than the ones which seem on the face of it to be more straightforward. If you're faced with a difficult case, it's not necessarily esoteric detail that's being requested of you. What's being requested of you is an ability to think logically and to try to demonstrate a clarity of thought in terms of proceeding towards a diagnosis and a management plan. Wetwali, I promised you some orthopedic questions. Here we are. Hopefully you can see some long leg standing films, and you can see an X-ray of the sort of the distal forearm, the wrist, in a child who's actually 11 years old, and both sets of X-rays were taken at roughly the same time. I think actually the wrist ones were taken a year earlier, but it's the same child. I'd like you to clearly explain to me, describe to me what you can see.
The X-ray of the distal forearm showing bony growth from the ulnar border of the radius.
Yes.
It's well demarcated with very narrow zone of transition. There is no. I can see also the radius looks. There's increased bowing of the radius. Most probably, it's could be malunited or a healed fracture of the fracture of the radius.
Okay.
Just proximal to the bony growth.
Yes.
There's no other lesions in the forearm. In the X-rays of the standing films of both lower limbs.
Draw your attention just to this area here.
I can hardly see this, some bony spicules arising from the radial border of the distal ulna.
Yes.
Also. Yes.
And so even on the forearm films, there's evidence that this may not be an isolated lesion, but it may be a condition in which multiple lesions, polyostotic lesions, arise. Now, and you correctly described what appears to be a lesion on the ulnar border of the radius, and a smaller lesion on the radial border of the ulna. You described what might have been a previous diaphyseal fracture, but we may come back to that in a second. Now have a look at the long leg films and tell me what you can see.
In the films, it is difficult exactly. I see these bony growths from the proximal tibia. It's like osteochondromas because the film is too small. I cannot see exactly.
Yeah, so you're absolutely right. What you're looking at here.
It is osteochondromas,
multiple osteochondromas. There's also some other things going on. If I draw your attention to
synostosis, I can see between the fibula and the fibula on the left side.
Yeah, there is a synostosis.
The fibula is short. The fibula is short, and this synostosis proximal between the fibula and the tibia. And
I'm just also then going to draw your attention to the coronal alignment of the legs. Is there anything you'd like to comment about? So the ruler's not dropped down completely midline, but it's nearly midline. Is there anything you would comment about the coronal alignment of the?
I can see on both sides. I see this valgus alignment of at the level of the hip and also the knee, especially on the left side, increased valgus angle.
So we have a condition here which seems to be polyostotic, affecting multiple bones. It appears to be causing osteochondromas, and it may or may not be causing some bowing of the radius, although I'm perfectly prepared to accept it might have been a previous fracture, and maybe some genivalgum, slightly asymmetric genivalgum. Actually, I haven't put the angles on, but the left leg was somewhat more valgus than the right leg. So what do you think would tie all of those findings in together? What is this condition?
This polyostotic lesion is most probably multiple hereditary exostosis.
Good. And do you happen to know the inheritance pattern?
It is an autosomal dominant
Very good.
inheritance due to AXT gene affection XT1 or 2.
Very good. That's exactly right. So it's an autosomal dominant inherited pattern, and there are two well-defined genetic defects in the EXT1 and the EXT2 genes. Just for a little bit of, so this is outside of the context of the Viva, just for your interest, actually the Evelina Hospital, St Thomas's in London, is further interrogating the different genetics and relating the different genetics even between patients with multiple hereditary exostosis and relating it to the phenotype, and trying to actually better relate the genetic basis to the phenotype, not only in terms of the number of osteochondromas, perhaps also the tendency for bony deformity, but actually also looking at long-term, lifelong malignant transformation. What are the treatment principles here, Charlie?
The treatment principles here is to maintain the correct the presence of if any deformities, to maintain the leg length, if there is leg length discrepancy, if there is any angular deformity, and to follow up to if there is any possibility of malignant change which is remote but should be considered during the follow-up of this patient.
Do you know, since you raise malignant transformation, do you know how you would differentiate an osteochondroma undergoing malignant transformation from one which you're confident was benign?
From the history, if there's any recent change in the size of the lesion, if there's a recent onset of pain, the second thing is the MRI of the lesion showing the size, assessing the thickness of the articular cap. If it's more than 1 centimeter, there is the possibility of malignant transformation.
Yes, it should be said that threshold 1 centimeter applies to skeletally mature individuals. So growth, pain, or a cartilage cap greater than 1 centimeter in depth in a skeletally mature individual indicates the likelihood or the possibility of malignant transformation. So, as with everything in orthopedics, to some extent, the treatment goals are maximize function, minimize pain, and that's the treatment goal here. Not to take out every lesion, not by any means, but to take out those lesions which are causing either pain or local compression effects, and also to make sure you maintain limb alignment. Thank you very much. I'm now going to hand on to, if I may, Mohammed Al-Rubi. If you'd be kind enough, Mohammed, to unmute. What's this condition? Have a look at, hopefully you can see an AP pelvis for hips and frog lateral of the same patient.
So I think I can be heard now. Is my voice clear? Yeah, so I can see an
loud
EP.
and clear.
Yeah, so I can see an EP and the frog position of immature pelvis, showing a decrease of epiphysis height in the left hip, I assume, with a sign of fragmentation. And there is radiological evidence of a vascular necrosis of this epiphysis, which corresponded to Percy's disease.
Yes. Okay. If I told you that this was a 6-year-old boy, and indeed that it was Perthes disease, firstly, how would you, and this was actually the first presentation of a 6-year-old boy with Perthes disease, how would you counsel his parents? What would you say to the boy and to his parents about you express to them what the condition is and how it's likely to be treated in the future?
So in my counseling of the parent of this child, I need to describe for them this problem as a problem which until now we don't have an exact cause for this problem. We actually understand there is a decrease of the blood supply to the growing part of the head of the femur. It can be sometimes just unilateral or affecting one side or affecting both sides.
Okay.
It has.
Let me ask you to pause there, Mohammed. If this were bilateral, and you brought up bilaterality, and you're absolutely right, Perthes can be bilateral. But if this if actually in a 6-year-old boy you saw symmetrical hips looking like the left hip, what other conditions would you have to consider?
Epiphyseal dysplasia, especially if there is a acetabular affection.
Very good. Any other? And so multiple epiphyseal dysplasia, possibly
Sickle cell disease, hyperparathyroidism, septic epiphysitis, sickle cell disease. A lot of differential diagnoses, but the most common bilateral hip and acetabulum affection is epiphyseal dysplasia.
Yes. So one has to also then consider is essentially the mucopolysaccharidoses and Gaucher's disease, which I think you're hinting at, but things like Hunter's and Hurler's and Sanfilippo's, etc. But yeah, that's absolutely correct. If it's unilateral, then the likelihood is that it's Perthes. We tend to get an MRI scan these days just to check because it's easy and it sort of crosses the T's and dots the I's. And you said that that it's a condition that we don't fully understand. I think it's completely fair. In fact, first described, of course, 1912, leg carving and Perthes, possibly by Waldenstrom in 1908. There was a conference in 2012 in which that was the overwhelming consensus that we, in 100 years, there's not very much discovered about it. But what are the principles of treatment? What would you regard as your goal in treating this 6-year-old lad over the next 2, 3 subsequent years?
So, according to the evidence-based medicine, there is a long follow-up series of Mr. Harding regarding one of the classification of the person's disease regarding the management. And he, according to the lateral pillar classification, classified the person's disease patient into 3 categories. The most important predictive factor is the age of the patient. So according to his long series, which has been done in more than 39 pediatric orthopedic centers, done by multiple surgeons and a lot of persons patients, they discovered that in a class A and C, there is no any effect of the treatment plan, while in a B category in particular, and in presence of the age less than 8, there is no need for doing anything. Above 8, the containment will be very effective to get a forward result, better result as regarding the shape of the hip and avoiding any complication of disfiguring of the proximal femur.
Yeah, I entirely agree with your description of Tony Herring's milestone paper. For me, it's some components of it are a little bit nihilistic. We're very lucky in East Anglia to work alongside a chap called Tony Catterall, who's retired now but used to work at Great Ormond Street in the Royal National Orthopaedic Hospital, and he's a very great expert in Perthes. The Prof Little out in Sydney, who I work with equally, and they would regard the principle of treatment as concentric containment. Basically, there's not very much you can do about femoral head collapse. There's been lots of techniques described, but none of them terribly effective. If one was terribly effective, we'd all be doing it. But you do want to achieve is concentric containment. So when the hip starts to subluxate, you need to do something about it. And an easy next thing to do, which applies to quite a lot of hip-related conditions, if you want to sort of hedge your bets and say something fairly neutral that can't be criticised, is to do an arthrogram. And I'm going to show you this picture of an arthrogram. There's a yellow line on my screen. I don't know if that's on everyone else's screen. But this is an air arthrogram, and I'm a great fan when I'm training my trainees how to do arthrograms, that they inject a little bit of air before they inject any dye, because I'm not sure if this expression translates universally, but it avoids blotting one's copybook. It avoids injecting a whole load of dye, which then obscures the region before effectively getting it into the joint. Good. Okay, I'm now going to move on, if I may, to Haytham El-Wadli. Haytham, would you be kind enough to unmute yourself?
Okay. Hello. Yes.
Okay. This is a super tricky one. Do you want to take on a super tricky one? So this is the sort of case, Haytham, where I'm not really looking for specific diagnoses. I'm looking for sort of broad brush categories. Okay. And importantly, okay, she's 5, because there aren't possibly the normal hints of skeletal development in terms of femoral head ossification and so forth on the x-rays. So she's 5 and she's on the first centile for height, i.e. if you line up 100 girls of her age, she would be the shortest in the 100 on average. Describe what you see and tell me what sort of broad category of condition you think this might be.
So this X-ray of pelvis and proximal femurs showing bilateral coxavara, and there is decrease. The head ossification is smaller than usual at this age, and also the acetabular trochanteric distance is shortened, and it seems to be regarding the history, she seems to be syndromic, so maybe she's dysplasia type of congenital coxavara. There is types, there is congenital, developmental, and acquired due to many causes like syndromic or dysplasia or due to infection or in other causes.
It is a dysplasia.
Yeah.
And you've described it beautifully, actually. There is coxavara, there's delayed epiphyseal ossification. What sorts of dysplasias, and yet the pelvis doesn't look completely normal, but the acetabulum looks relatively well formed. What sort of dysplasia do you think this might be?
Yeah, mostly physical dysplasia.
Yeah. Okay. So
that's affecting the faces mostly.
So this could potentially be a multiple epiphyseal dysplasia. As it happens, it's not. It's spondyloepiphyseal dysplasia, but it could be equally either. What sort of thing? So what do you think are the principles of treatment in a condition that I'm willing to bet you've never treated? In fact, you may not have ever even encountered somebody with spondyloepiphyseal dysplasia.
Yeah.
And that's not the point in a sense. The point is, what are the orthopedic principles that we would apply to this, for you and me both, relatively unfamiliar?
So the principle of treatment of correcting the coxavaras and with derotation proximal femoral osteotomy to restore the neck shaft angle and also reduce the Hilken-Liner epiphyseal angle, and also restore the as a stabler trochanteric distance, and also sometimes we need to achieve normal anteversion of the femur and to get the physial line more transverse to allow healing and avoid any more virus.
Very nicely expressed, and in fact that is not the next step that I took, but it is the step that I took, as it were, having leapfrogged the next step. So this girl now has had bilateral valgus proximal femoral osteotomies, but I'm going to take you back to what I said to Mohammed about hips. You can very, very rarely be criticized by doing an arthrogram.
Absolutely.
And this arthrogram for me is interesting. It shows that actually, as you abduct the hip, the medial pooling increases, i.e. the hip subluxates. As you adduct, adduct, as you cross the legs across, actually the congruency of the hip was improved, and that's why I was very confident to do a valgus osteotomy. Thank you. Let us now move on to Akshay Bawa, and then after this next case, I think I'll hand over to the wonderful Mr. Pranay Gurudeva, if Pranay is ready. So, oh yeah, no. So this is I trust for you. Actually back into possibly more familiar territory. So hopefully you can see again a frog lateral and an AP pelvis for hips. Would you like to describe what you see? Could you unmute? Are you?
Hi, can you hear me?
I can, thank you.
Yeah. So these are AP and frog-leg lateral radiographs of the
And
skeletal.
thank you for putting your video on. I like to speak to people as close as possible to the concept of face-to-face. Carry on. I recognize it's not possible for everyone.
So these are AP and frog-leg lateral radiographs of the skeletally immature patient. They're showing that especially on the right hip, the Klein's line is passing above the epiphysis. So this appears to be a case of slipped upper femoral epiphysis. The left hip seems reasonably normal to me.
So actually, if I told you that this child had, this is a 14-year-old boy, it was a real case who I have operated on, a 14-year-old boy who actually had been limping on and off for 6 months, but he could walk. How do you classify slipped upper femoral epiphyses in a way which both guides management and predicts prognosis?
So that would be either an acute or a chronic slip. In this case, it's a chronic slip. I can see on the radiographs that there's some calcification inferior-medially, which points that there's some attempt at callus formation. So this, as you said, has been going on for about 6 months.
There's some metaphyseal beaking, which hints at the chronicity. That's not exactly what I asked, though, if I may. I would like you to tell me what feature of this child's presentation, clinical or radiographic, actually best predicts prognosis and guides management.
So that would be based on Loder's stability classification. So stable versus unstable, depending on whether they were able to weight bear or not. So this child can weight bear, so he would be classified into a stable slip, and that basically quantifies the risk of AVN. If they're unable to bear weight, then there's a 47% chance of avascular necrosis of the hip.
Very good. So how would you manage this child? Your consultant on call, so you're 2 or 3 months into the job, and this child presents to the emergency department. Mum's frustrated that the GP is not properly examined the child. When you examine the child, the child has a pronounced limp, walks with rotated foot progression angle. You actually prop him up on his on the examination couch and flex the hip. It goes into sort of radical external rotation. That is to say, as you flex the hip up on the left-hand side, and you can touch the knee to the shoulder. Flex the hip up on the right-hand side, and the knee swings way out laterally. And in fact, his heel comes across his tongue. What are you going to? How are you going to manage this child?
So the principle here is to arrest the slip progression. So we want the slip to be at the place that it is now. For that, ideally, this is best managed by a pediatric orthopedic surgeon who is adept at dealing with severe slipped upper femoral epiphysis. But
okay, even if you are going to choose to phone a friend or transfer this patient, what measures are you going to institute essentially immediately?
So I would.
How could you definitely make this young man's hip worse?
So by attempting an acute reduction. So that would,
no, so I don't think you would achieve anything by attempting an acute reduction because of the chronicity, because it is stuck. The way you could make this child's hip worse would be to turn it from a stable hip into an unstable hip. And so actually your duty, your responsibility as the diagnosing surgeon is to ensure that you minimize, ideally eliminate that risk. And that, so first of all, you actually ask him to be non-weight bearing, as simple as that. Now, let us imagine that that you are this time at the receiving hospital, and that you are in the position of being the receiving pediatric orthopedic surgeon. What options are open to you? How would you advise the parents? How would you consent the parents? What would you actually do if you were not the man passing the buck, but the man receiving the buck, the man not passing the baton, but receiving the baton?
So I would opt for in situ pinning of the right hip, but I would explain to the parents that the options essentially are to, like I said, the principle is to arrest the slip progression and then deal with the deformity later. That would be in my hands, but there is also an option, and it is done very frequently in other centers, to correct this deformity in one go and then pin the hip.
Yes. Do you know how that surgery is performed? Do you know any of the eponymous operations described?
So that would be with a done osteotomy to.
And what do you do with it in a done osteotomy?
So essentially, you're trying to reduce the neck back in line with the epiphysis. That is with that is making sure that you preserve the vascularity to the hip while doing that.
So the word to bring into your explanation is cuneiform. You take out a wedge of metaphysis. Very nicely answered. I operated on this child, and I did exactly what you suggested first. I did in situ pinning, and we will come back to fight another day, possibly depending on what the child chooses in the future. Now I'm going to, if I may, hand over to my colleague, Mr. Budadev. Pranay, I'm going to stop sharing now.
Hi everyone, and thank you, Mark. So for those of you who don't know me, I'm Pranay Budadev. I'm a consultant pediatric orthopedic surgeon between Broomfield Hospital and Addenbrooke's Hospital in Essex. So I think these sort of sessions, there's quite a lot of you here. There's probably around 75 of you here for questions. And I really want everyone to get as much out of this as possible. And I think to do that, what we're going to do is we're going to go through a sort of quick fire round of cases. So if everyone can get a sheet of paper and a pen, we're going to start, and we're going to go through 30 different pediatric orthopedic cases in quick succession. And then we're going to go through the answers of them and give you the opportunity to ask any questions, because the issue with the FRCS is you may not get the standard question that you expect to get. You may not get the DDH, the Perthes, the SUFI, the clubfoot, the basic trauma. And therefore you need to be aware of the other things that can pop up and just stay calm and understand how to deal with them. Okay, so if everyone has that, I'll start sharing my screen and we'll move on. Okay. So, 1 second. So I'm going to time this, and we're going to spend 30 seconds per slide. Okay, so there's not going to be much talking for the first 10 minutes or so, but then after that we'll be able to do whatever we need to do. If you have any questions, I'm very happy if you just unmute and interrupt me, but we need to move on pretty swiftly to get through this in a timely manner. So I'm going to put up the first question, and we're going to start our 30 seconds now. So this is an X-ray chest of a neonate. And there's 3 questions here. What do you think the diagnosis is? How would you manage it? And what other things can you consider it could be, or you could be concerned about? Okay, so just 3 short words on there, and hope you've got those down. We're moving on. This is an X-ray again of a neonate. Can you identify or provide us with the diagnosis and how you would subsequently manage this patient? These are quite important things to recognize as a consultant, even in a district general hospital or anywhere, really. We'll move on. Here's an X-ray spine, once again, of a young child, just 4 months old, under my care currently. Can you provide me with the diagnosis for this patient, the cause for the diagnosis, and how you would manage them in the very first instance? Okay, we're moving on, 30 seconds, we're going quick here. X-ray of a foot in a 6-year-old boy presenting with pain, swelling, difficulty weight bearing. If we can have the diagnosis and the subsequent management, how you would manage this patient in your fracture clinic if they came through the front door. There's only 2 here, so we'll move on quicker to slightly more complex one. A lot more obvious clinical picture and supported by X-rays in a neonate again. Can we have the diagnosis, how you would manage this patient in the very first instance, and what further investigations or associations are in keeping with this clinical presentation? Can't see most of you, so I hope you're keeping up and writing down really quickly. We'll move on again. I think this may be reasonably similar to one you've seen before today, but if we can have the diagnosis of this patient, the inheritance patterns of the communication, and the gene that is affected. Next one will be pretty obvious, but it is, once again, in a young neonate patient. What is the diagnosis? What would be your management knowing that this child is a brand newborn neonate child? And what are your further considerations? What are the most important things that you need to do when approaching this child in this clinical situation? And I hope you're keeping a lockdown. We're going to have scores of the doors at the end. So everyone can submit their scores. So Next patient. Another trauma, slightly older child, around 10 years old, had a twisting injury. Can we have the diagnosis of this patient, how you would manage it? In the first instance, it's come on your general trauma on call, and what your concerns would be with regards to this fracture. And this was a case that I was given in my FRCS. Okay. Something most of you would have seen before and stayed up at night managing. But if we can have the obvious diagnosis, the classification and what this one would be, and again, how you would manage this, I'm sure the FRCS mentors can viva you with regards to some of these more core critical topics later on. So here we have an AP pelvis in a 14-year-old runner presenting with right-sided pain. If we can have the diagnosis, how you would manage this patient, and what you may be concerned about or any further considerations. Any other tests you would do, anything else you would advise, etc. This is a clinical test that I expect everyone to know and understand why it works. So can you name the test? I'm sure you've all done this. You would have done it in foot and ankle rotations, in pediatric rotations, and neuromuscular patients. And then we'll talk about image A and what we are doing, and image B. What are we looking for? What is the tight structure? Or what would you have to manage in image A versus image B? Next one, clinical photo of a newborn with associated x-rays. This is a congenital deformity that we would see. So diagnosis, the management of this patient, and what your further considerations are for the future when looking after this patient. What would you advise the parents or explain to the parents would be an issue or potentially an issue in the future? Next, we have a clinical photo of a foot. I would say it has a particular shape to it, especially with regards to the sole of the foot, and an associated x-ray, hopefully helping you identify what the issue is. And are you aware of how these patients are managed? 3 seconds and moving on. Again, a patient who presents with the below x-ray. You can see the clinical x-ray of the limb and the foot with the associated long leg x-ray. Just give me the clear diagnosis that this child has and how you feel they should be managed. Something slightly more complex with regards to this one, but if we have an AP pelvis in a child, obviously, so let's have a diagnosis. What is the important measurement that we would like to know about, which helps guide our clinical treatment of this child? What are the potential causes, and subsequently the management that can be applied to address that? So 4 marks with this one. There's not many with 4 marks. We're halfway through already. Here's a clinical photo. The resolution and coloration of the x-ray is absolutely fine. This is what it appears like. I have not adjusted any shading on this. And we have the diagnosis, the pathophysiology, what causes this condition from a bone cellular level, and subsequently, what are the risks associated with this condition? Next, x-ray, right femur in a child who presents with pain, was playing basketball, no problems, but presented with pain that then began to cause issues at nighttime, has an obvious swelling in the thigh. Can you tell me the underlying diagnosis, the radiological signs that we're looking for, and how you would further investigate this child? Again, one not to be missed. X-ray of a distal femur in the child. Can you give me the obvious diagnosis? And then what arrow 1 and arrow 2 is pointed to? What is the name for the 2 regions of bone affected? And what's the appropriate nomenclature? Clinical photos and wrist X-ray of a child with an obvious deformity. Pretty clear cut. We can have the diagnosis, what the inheritance pattern is, and what is the key anatomical structure that causes this deformity in the wrist. And myself and Mr. Latham have both recently managed a couple of patients with this condition. I'm letting it go on a few more seconds so you can scribble down. We'll get on. Patient who presents with pain on the medial aspect of the foot. Can we have a diagnosis, a classification, and what your management would be? And this is a 9-year-old child, if that helps any of you. It's the medial aspect of the foot that is painful. 5-year-old child presents with this X-ray, walks, waddles, late presentation. What is the obvious diagnosis? Can you name 5 risk factors, which you should all know about? This is a core topic. And subsequently, how you feel this patient should be managed, understanding that they are 5 years old. Want to puzzle a few of you. This is an X-ray of a pelvis in a 13-year-old. We can have a diagnosis, and if you can give me the eponymous name, that's a bonus point. You may have seen it, may not have seen it. Don't worry, it's just there. You don't need to know much about it. What is the name of the procedure and the approach that has the needle in this image here? What is the obvious pathology? And can you name what 1 and 2 are pointing at? And we'll talk about that. Just 7 more to go, but getting there quickly. Here we have your typical presentation in most hospitals, and a 12-year-old girl was walking and suddenly fell to the ground and had to present to the hospital. What's the diagnosis in this radiograph? What are the anatomical associations? What are the things that we need to assess in this child, both clinically and radiologically? And what is the name of the main ligament that is usually stretched or torn in this injury? Here we have X-ray AP and lateral of a 5-year-old child who presents with a clinical deformity. These are the X-rays for them. Can you describe the deformity? As you can probably tell, there is a bowing of this tibia fibula. So what is the underlying diagnosis and what are its associations? This is a 12-year-old child that presents with no trauma. There's no trauma associated with this. Presents with a prominence over the right upper chest. If so, no, understanding that there's no trauma, can I have a diagnosis, a cause, anatomical cause, and management? How would you manage this patient? Back to something we're more familiar with. We have the name of this issue Please don't get distracted by the obvious. Have a close look at the X-ray. What is the diagnosis for this patient? It was a major trauma accident. How would you assess this child, and what would be your management? We're coming down to the last three. I think this we've been through, but please just write down the obvious diagnosis. The risk factors associated for this to occur in a child. And I'll mention briefly the management that can be undertaken. Final two, we're only 10 seconds behind where we planned. Significantly shorter leg, one bone predominantly affected. Diagnosis, how it can be classified, and subsequent management. And finally, X-ray and CT scan. We have a diagnosis for the lesion. In the history, what is it typically improved with, medication-wise? And subsequently, how can we manage this patient? Okay, everyone happy? Let's all have a breather for 30 seconds. Okay, there was a lot to go across there, and we'll start from the top in a few seconds. Tick away your answers, keep a log of your scores, and then we'll get them put into the chat box. Again, I'll go through them relatively quickly, but if you have a question, if you can please unmute yourself and also or put something in the chat box, that would be really helpful, just because I'm going to try and get the chat box up on my screen as well, so we can have a look. Okay, so we'll start from here. So number one, diagnosis is actually a clavicle fracture that was caused by birth. This was the same child who had an X-ray at 3 weeks, and you can see significant callus healing there. Management, conservative. They're neonate, it will heal. And what are your other considerations? Well, could it be a pseudoarthrosis of the clavicle? And non-accidental injury if it was not an immediate birth injury. Okay. Next one. This is really important, and this is something that people tend to miss quite often. This is a physeal separation. Okay, this was a birth injury in this child. What do we mean by physeal separation? It's essentially a Salter-Harris 1 fracture, where if you go to this is the metaphysis. The epiphysis is still cartilaginous. You cannot see it and is actually reduced. This is not an elbow dislocation. And that's the most important thing to understand. This needs timely treatment. It is associated with non-accidental injury, so does need to be looked at. And how do we do it? Normally we do a manipulation, an arthrogram to confirm appropriate reduction, and K-wiring. Okay. Next one. Hopefully most of you got this. Diagnosis is congenital scoliosis. Okay, as a young child. What is the cause? In this case, there is a hemivertebra that you can hopefully identify here, which is the apex of the curve. And this is obviously due to a failure of formation. There is obviously a failure of segmentation as well that you need to be aware of. What do you do? Well, typically you would observe it, and they can be excised later down the line if it's not improving. And this defect forms is an issue with the formation of the mesenchymal analog during the 4th or 6th week of gestation. So you can get a bar, which is your failure of segmentation, or you can get failure of formation, which is hemivertebra, just as in this case. And for this child, you can see they've actually got multi-level issues with their, we've sent this child off to Great Ormond Street. 6-year-old child, I think I said before, so diagnosis, Kohler's disease, avascular necrosis of the navicular, common thing to see, commonly seen in a fracture clinic. How do we manage it? Essentially, non-weight bear them and symptomatically manage them expectantly. Give them a cast if it's really severe. Most patients can get around on a boot, and it does improve over time. Number 5, newborn child. This is a congenital knee dislocation, usually caused by very tight quadriceps tendon and subluxation of the hamstring, which then causes this extension moment. How do we manage it? Serial casting of the knee in gradual flexion. In fact, I probably have the same patient here. So this is the Tarek classification, which basically depends on how much passive flexion they have. So it's either greater than 90, 30 to 90, or less than 30, as you can see, if it's quite severe. Management is serial casting, and the association is with DDH and torticollis. So always get a scan. The last patient I had with a congenital knee dislocation also had a graph 3 dislocated hip that we had to manage in a Pavlik harness. Mark went through this one earlier. This is multiple hereditary exostosis. It's the most benign bone tumor. Inheritance patterns is autosomal dominant, so it is quite common to see it in families, of course, and it's the EXT1, 2, and 3 gene. Okay, we don't need to go through this much anymore. Any questions so far? Please just unmute. Otherwise, I'll carry on in a few seconds. Okay. So obvious fracture. I said this was a neonatal. This is a neonatal femoral fracture. How do you manage it? Pavlik harness, okay, or with no treatment whatsoever. This is the same child when I saw them a year and a half down the line, completely healed, completely remodeled, no leg length discrepancy. But you do need to look at the leg lengths as you follow these children up. Obviously, if you have a young child presenting with a femoral fracture who is not of walking age, of course, non-accidental injury, that needs to be investigated for child safeguarding. And you must mention that when you see in the pediatric station any sort of fracture, you need to always mention the word safeguarding. It's very important. This is the case that I got given in my FRCS exam. This is a Salter-Harris 2 fracture of the distal tibia with a high fibular fracture. How do we fix it? Well, you can fix it just through manipulation. You can hold it with a screw, A to P. You can hold it with a K-wire, dealer's choice. But what is the concern? The concern is this. The concern is a growth arrest that can happen and cause an angular deformity around the ankle. So the third mark for that was looking for growth deformity later down the line. Supracondylar fracture, Garden 3. How do you manage it? Depends on the mechanism of injury, but you need to approach the child with ATLS protocol, ABCs, assess their neurology, make sure you document individual nerves, including the anterior interosseous nerve, which has gone in quite a few numbers. Must ensure there's a radial pulse to document the perfusion of the hand. Obviously, child needs to go to theatre, MUA and KYs, dealer's choice with what you do. There's evidence for both lateral and medial KYs. If you want to start mentioning evidence, you can talk. We have our BOSE guidelines, obviously, if you're doing the FRCS in the UK, to mention 2mm wires, can be lateral or cross, but if you're doing a medial side, then you must open and have a look to ensure you haven't penetrated the ulnar nerve to at least retract it. This one here is a right neck of femur in a 15-year-old runner, fracture across here. Obviously, the classification is a Delbet fracture, and this is the Delbet classification, and that essentially asks, is it transphyseal, transcervical, basicervical, intertrochanteric? So slightly similar, but obviously the AVN rates are quite significant when it's transphyseal and it's associated with or without a epiphyseal dislocation, which essentially is a SUFI, if you think about it that way. But cervical also is the most common one and also has a 30% risk of AVN. How would you fix it? Cannulated screws, aspirate the joint of its hematoma. And other things need to be looking at is obviously could be a stress fracture, low vitamin D, and things like that. Number 11, so this is a Silver Skulls test. I feel like a lot of people don't tend to understand this. So with the knee straight, both the gastrocnemius and the Achilles tendon are tight. Okay, you have to collect the heel position. And if you've got tightness and you have that equinus deformity, that tiptoe walker, if it improves with knee flexion, that means you have relaxed the gastroc soleus in its entirety. And that means if you still have tightness with the knee flex, it is truly an Achilles tendon issue. Most, I would say, would be like B, where they're tight with improvement with the knee flexion, which means you relax the gastroc, which means it's a gastrocnemius tightness, and that's very common in neuromuscular disease. The name of the test is Silver Scold, SILVER SKIOLD. Okay, thank you, Nikki, for putting that. Great. This also allows you to then decide on how you treat it, because if it's an Achilles tendon issue alone, then you can do a percutaneous or tender Achilles lengthening, as sort of shown here. Or if it's the gastrocnemius, which in most cases I found in my patient cohort it is, you can do a gastrocnemius recession, which is essentially lengthening what I tell the parents is the shirt that sits around the muscles and allows it to stretch. Very, very useful, and you don't then have to touch a tendon. Diagnosis. This is the posterior medial bow. What do you do with it? Nothing. Observe. It improves. But what are the further considerations? Leg length discrepancy, 2 to 3 centimeters at skeletal maturity. So I just watch these. The most telltale sign is that you can essentially touch the dorsum of the foot up towards the shin. Obviously, the apex of the bow is both posterior and medial. So whenever you see one of these funny bows, look at the apex. Where is it? It's at the back. It's on the inside. It's a posterior medial bow. That will help you a lot when you get seen some of the more complex ones. And as you said, the leg length discrepancy is the one thing that we watch out for, and we have our very clever ways of guiding growth these days. Diagnosis. This is a Persian slipper foot or a rocker bottom foot. Hopefully you could identify that the talus is almost vertical. And if you look at the line, if you draw between the talus and the first ray, it's completely non-linear. They're completely off. How do we manage this? Typically with a reverse Ponseti casting method. So that would be the first one. So do reverse Ponseti casting. That essentially loosens up all the soft tissues. And then we do an open reduction and wiring of that. Mohammed's asked number 12. Number 12 was posterior medial bow. There is no other diagnosis. It's just posterior medial bow. So 13, congenital vertical talus, reverse Ponseti technique, and open reduction and casting. And this is the open reduction. You actually see you sitting yourself, and then you wire it usually. Well, you can do it. I do it retrograde like this, and you can see I've gone through the base of the first metatarsal into the talus and hold it in that way. Diagnosis of this one. So to be pretty simple about it, look at the bow. So the bow here is again medial. If we show you a lateral, it'll be anterior. This is the anteromedial bow. And this patient has missing lateral rays, okay? This is fibula hemimelia. And the way you can remember it is it's an anteromedial bow, me, familia, fibula hemimelia, okay? And I'll tell you why, because on the next one, we'll have a look at something else. These are some complex and more complicated cases. As you can see, you've got your anterior, it's anterior bow, it's a medial bow, it's much more significant. There is a classification. I don't think you really need to know this. And obviously you can either observe it and then there will be reconstruction options. This can also be associated with proximal femoral focal deficiency and absence of the ACL. So I have a patient currently with very mild fibula hemimelia, basically has 4 toes, no significant other findings, just slightly shorter fibula, has a ball and socket ankle joint and an absent ACL. And so we're actually managing his ACL because that's the big issue for them at the moment. Next diagnosis, this is a congenital coxavara. It's bilateral. It's a problem with the ossification of the femoral neck. What are causes for this? Congenital development. It can be autosomal dominant. It could be acquired. It could be following trauma, Perthes, Sufi. But, you know, this is an obvious congenital coxavara. What line are we talking about? We're talking about the HE angle, Hilgenreiner epiphyseal angle. As you can see, the Hilgenreiner line, the epiphyseal angle. If it's 45 degrees, it's likely to correct. If it's 45 to 60, watch and wait, 60 degrees plus, surgery, typically, if the femoral neck is less than 110 degrees of angulation, as you can see here. And what I did for this one is I did a bilateral valgus osteotomy. This one may have confused a few of you. This is osteopetrosis, okay, essentially marble bone disease. It's caused by the pathophysiology is defective osteoclast resorption. There are 3 genetics type, and essentially there's inability to acidify the Howship's lacunae, and there's a lack of ruffled border. That I would say is the sort of magic phrase on your FRCS part 1 is the lack of rougher border, defective osteoclast. You can't resorb the bone, so it just gets harder and harder and harder. Osteoblasts keep on working, laying down more bone, and they can actually present with quite significant fractures. And because you get this other view, which is a bone within the bone, it can actually end up leading to anemia as the marrow is unable to produce hemoglobin, and you can also get increased risk of osteomyelitis, again, because of the stagnant blood flow. A very important case with this, I hope you picked this up. This is actually a Ewing's sarcoma. There's the onion skinning found of the periosteum. This was a 15-year-old, night pain, able to walk, but has pain with an associated swelling. Further investigation would be MRI scan. You see a significant tumor here, and they're large soft tissue components. That's hot on the PET scan, and actually about 25 to 30% of them already have metastases on presentation. If you're doing the part 1 histology that you tend to find in ortho bullets is round blue cells or pseudo rosettes, and treatment is chemo, limb salvage, and then radiation. So quite horrible things to have, but important to pick up. This is chronic osteomyelitis. That's the diagnosis. The metaphysis, as the vessels make a sharp turn, basically happens in this area because there's sluggish blood flow. What is one? One is sequestrum, necrotic bone, which has been walled off from its own blood supply. And 2 is the involucrum, okay, a layer of new bone forming outside the existing bone. So osteomyelitis, chronic osteomyelitis, sequestrum is 1, involucrum is 2. Apologies. There we go. The patient that me and Mark have recently had, this is the Madelung's deformity. That's the diagnosis, essentially a congenital dyschondrosis of the distal radial physis on the volar side. It's autosomal dominant. You get under inclination of volar tilt, growth arrest of that part, and essentially the anatomical structure is the Vickers ligament. Okay, the Vickers ligament, which is the short radiolunate ligament, and that's what you would release in this child. Okay, it's autosomal dominant, as I sort of mentioned earlier, and it can be linked to a condition called Levy-Wild dyschondrosteosis, which is where they also get mesomelic dwarfism. This is the X-ray of the foot, painful on the medial side. This is an accessory navicular. About 10% of the pediatric population have them. 70% of them are bilateral. There are 3 different types: type 1, type 2, type 3, depending on if the bone is essentially a sesamoid within the tendon, which causes pain, 2 when it's separate, or 3 when it's just global enlargement. Procedure is a Kidner procedure, which is basically open, excise, and advance the tibialis posterior tendon on there. Okay, last 10. I know we've gone through a lot already. Bilateral DDH. This is teratological risk factors: firstborn, female, breech, family history, large birth weight, oligohydramnios, twin pregnancies. Take your own pick. Okay, you need to know about the NIPE screening that we have in this country. How would you treat it? Well, if you've got a child young enough, you can do a close reduction. Unfortunately, in this child, they were 5 years old, as I mentioned. They needed what I call the full shebang, which is a femoral osteotomy. That's a shortening derotation osteotomy. They don't need a varus. You then do an open reduction and a pelvic osteotomy, and this is the child after they've had staged. This is one just to get you in the mix for some, maybe it's even some of the faculty. This is disappearing bone syndrome, which is massive osteolysis with proliferation and dilation of lymphatic vessels. Eponymous name is Gorham-Stout syndrome. Okay, Gorham-Stout syndrome. Don't need to know this for the exam. It was just in there as an extra. What's happened here? Patellar dislocation. Patellofemoral instability is very common and it's very complicated. So you need to understand, what are the anatomical considerations? Well, has this child got patella alta? Is it too high? Is it sitting within the notch appropriately? Is the notch appropriately formed? That's trochlear dysplasia. Do they have abnormal version of their femur that can subsequently tilt the way that their distal femur is like, and therefore it slips out? You need to know about the TTTG distance, hypermobility in these kids, and the main ligament was the MPFL ligament. This child they had it was patella alta, so we did a tib-tub transfer for this child in addition to an MPFL reconstruction. Nearly there, 25, describe the diagnosis. Okay, once again, let's look where the apex of the bow is. It's anterior and it's lateral. It's an anterolateral bow, okay? Anterolateral bow is congenital pseudoarthrosis of the tibia, associations, neurofibromatosis. I won't take it more further than that. Here we go. There's lots of different things. There's a whole bunch of different things you can do to identify if it is neurofibromatosis. There's 7 different types. The vast majority are like this. You need to be looking for cafe au lait spots, etc. Okay, this one I said was atraumatic and had been there for a long time. This is actually a congenital pseudoarthrosis of the clavicle. If we were talking about a fracture, I'd be very keen to tell everyone, do not operate on them. They do heal by themselves, and there's some new papers in the BJJ to do that. Mohammed, 24, was patellofemoral instability, and we talked about that. So here, congenital pseudoarthrosis, and it's essentially failure of fusion between the lateral and medial ossification centers of the clavicle, and what's the cause with this is essentially your subclavian artery that essentially pulsates and stops it from fusing together. Failure of fusion, you get extrinsic compression of the subclavian, usually more on the right-hand side, unless the patient has situs inversus. How would you treat it? Well, you round the edges. You can imagine conservatively, but if worse comes to worse, you can fix it like you would with fracture. Oh, so yeah, we're coming up to, did I miss one? I may have missed one. Oh, apologies to all of those. 23, as you said, sorry, I missed this. So go back to your scores. 23, this is an arthrogram. The needle's coming medial. So this is a subadductor, because you would go subadductor medial approach. The diagnosis is obviously DDH. What's number 1? It's your dipooling, your medial dipooling, because the hip joint is actually empty. 2 is your rose thorn, because there's capsular constriction due to the psoas tendon. Apologies. Thank you for making me do that. Let's go to 27. 27, we'd already had a supercondylar, so I hope we didn't make the same mistake. This is actually a floating elbow. As you can see, the child also has a wrist fracture and an elbow fracture. You have to be aware that there's a high risk of compartment syndrome. You need to be very vigilant with your neurovascular examination. How would you manage it? Well, I wired both on the same day and got them sorted out. 28, severe SUFI. As you can see, risk factors, obesity, hypothyroidism, other hypogonadism, skeletal immaturity, low vitamin D. There's some new things like acetabular retroversion that have been cited with this. Obviously, you want to check if the blood flow is there for vascularity. How would you acutely do this? Well, this is, as one of our colleagues mentioned earlier, which was an immediate modified Dunn osteotomy, surgical hip dislocation, identifying the slip, putting it back on, nibbling off the metaphysis, holding it on, and then checking its vascularity. I think if it's an acute severe slip, it would be completely reasonable to say I would either discuss with my young adult hip colleagues and my pediatric colleagues to perform an urgent reduction, surgical hip dislocation reduction using the Dunn method. I think the fact that you know about that and what the risks are, which is obviously AVN, that's absolutely fine. This is the Gantz approach. This is a Gantz surgical dislocation. Okay, we've taken off the great trochanter. So I'm just looking at the chat at the same time. Taken off the great trochanter, flipped it over, essentially put a wire up the neck into hold that, dislocated as one. And any role for traction for acute SUFI? No. I think unless you're getting to it on the very first day and within the first 6 hours or 12 hours, that's the Parsh technique where you can do essentially a close reduction and pinning. But the AVN rates are pretty high. So I think it would be pretty safe if you see this, that you would refer to a center that manages this regularly. And you can also do it, as Marcus said, you can do an anterior approach, direct anterior approach, and do essentially a subcuneiform osteotomy. That's essentially the fish, which is another one where you leave it in situ, you take out a bit from the neck. But I think this is a pretty standard answer for FRCS. That's what it looks like following. And obviously we did the other side. This is a funny screw. It's called a Pega screw because this child was only 10 years old. It's a growing screw, but I think contralateral pinning is a debate of its own. Last two, here we have a significantly shorter leg, proximal femoral focal deficiency, or congenital shortening of the femur, whichever one you want to talk about. Classification, the Aitken classification, which essentially allows you to say, is the femoral head present or absent, and then describe how dysplastic the acetabulum is. This is, how would you manage it? Well, most people would say lengthening, but if you're ever going to, I've never seen this procedure, but you know, the Van Ness rotation plasty is something we've always wanted to see. Most now with growing nails, we wouldn't put nails in and bring them up. Final one, sorry, it's taken a while. It's a radiolucent lesion surrounded by sclerotic bone. It's the nidus. What are we looking for? What are we looking for? This is a osteoid osteoma, and the improvement happens with NSAIDs, i.e. ibuprofen. How do we treat it? Radioablation. Okay. If everyone wants to count up their scores and put them in the box, it'd be great. But I hope that sort of made you quickly feel comfortable with a lot of things you may or may not have seen before. May just be as helpful for those of you who are waiting to do the part 1 of the exam as opposed to part 2. And I'm sure the FRCS mentors can further quiz you guys on some of the more common topics. But I hope you've now had to understand with that. Thanks very much. I'll pass it back to you, Mark.
Thank you. Thank you so much for that. That was a really great presentation. Might have used up a lot of our questions for the mentor group, but we can still ask more. Yeah, and that was great. So what I wanted to say, those of you who will know me know I like to take 3 things away from everything, because 2 is lazy and more than 3 is greedy. But the first point I wanted to make was at the very beginning, when Mr. Latimer was showing you the shark fin or the dolphin fin, whatever it was. I think sometimes when you are in the headlights of an exam, your head is going everywhere trying to think of things. And basically your opening slide is just describe what you see. So I know one of my colleagues used to put an apple on the table and ask the trainees to describe what they see. And it's just a way of kind of focusing your head, getting you into that exam kind of pattern, and then you can relax a little bit as you talk about things you know about. The second point I wanted to say was, you will have heard a lot of keywords mentioned, and these are things that you need to bring out when you're talking. So words like polyostotic, concentric containment, make a note of these words and put them up, because it really shows that you understand what you're talking about and you're familiar with it. And the third thing I wanted to say was, you know, all the cases that we've just been through, you can get any of those. I'm sure I've had some of those in my exams. They're in the questions that we ask you because they do come up. So, you know, just work through what you can watch this recording again and go through those cases and make sure you understand what they are and what you're looking for, because they're all fair game. Right. So do we have any questions from the audience? I've not seen any in the chat.
No questions that wasn't already answered by Mr. Latimer. Could I just add to what you said, Nikki, about reviewing the recordings? Could I make a strong suggestion that when you are reviewing the recording on either on the RUK website or on the YouTube channel, please pause for every slide that Mr. Budova puts up there and practice answering it. And then go and look at the answers that you have got, comparing it to your textbooks and so on, and then write out your perfect answer, because literally you've covered everything in what would potentially come up. I don't think there's a topic there that you haven't covered. Really well done there. Really appreciative of that. Thank you.
Thanks, Sean. So well done to everybody that volunteered. You know, we've been watching you for a while now, like stalkers. But you know, certainly coming along nicely, I would say. I was very impressed with a lot of your answers, especially at the beginning. And your technique's definitely improving. So what we're going to do next then is we are going to thank our speakers for that great presentation. And we're going to move on to the Viva practice. So let me stop recording.